So hello everybody and welcome to this ESGE webinar today, Wednesday, 1st of June. And I'm Ivo Boškoski and I'm the chair of this session. And I'm very happy and thrilled to present you three world-known experts that will talk about advancing the role of endoscopic ablation therapies in bariatrics. We have Oscar Victor Hernandez Mondragón from Mexico, we have Manoel Galvão Neto from Brazil, and then we have Vivek Kumbhari from USA. So this is the fifth consecutive year that ESGE offers you the opportunity to do these very important webinars with very nice teachings and very nice presentations, in order to view high quality presentations on hot endoscopy topics from world leaders in endoscopy, just like today. And remember that to interact with the speakers, you have the Q&A box just down below on your screen. You can ask any kind of question. Today we have three lectures, and we have the questions and answers at the end of the three lectures. I'm introduce to you Dr. Oscar Victor Hernandez Mondragón, that will talk about new anti-reflux ablation therapy, the ARAT, on gastrointestinal reflux disease. So please, Oscar, you can start your presentation now.
Thank you very much, Ivo, and thank you to the European Society for Gastrointestinal Endoscopy and the ERBIC company. So my name is Oscar Victor Hernandez Mondragón. I am chief of the endoscopy department in Mexico City, Mexico. And we're going to talk about the new anti-reflux ablation therapy that is called ARAT on gastroesophageal reflux disease. Well, as you know, the objectives of APCUs, the therapeutic effect, include the tissular damage of several gastrointestinal layers up to the submucous. But if muscularis propria is damaged, complications could appear, such as perforation or peritoneal inflammation. When we use hybrid argon plasma, the safety is increased, maintaining the therapeutic effect. And in ARAT, we look for a controlled esophagogastric junction tissular cicatrization. As you know, GERD consists on troublesome symptoms or mucosal damage resulting from retrograde movement of gastric contents through an incompetent esophagogastric junction that affects quality of life. This is a high prevalent condition that affects more or less between 8 and 33% of worldwide population, with clinical effects on GERD that consist of esophagitis, stenosis, Barrett's esophagus, or even adenocarcinoma. And this has high burden of costs. So why we should look for endoscopic treatment? First, we have some drawbacks about the medical treatment. The long-term PPI use has been associated with several adverse events that goes from 2 up to 12% of patients, including infectious complications, nutritional deficiencies. We have to be cautious in patients, in old people, malnourished people, immune-compromised people, and chronically ill patients. And the most important thing is that this therapy doesn't affect the esophagogastric junction barrier, and there is no clinical response in up to 30% of the patients. And how about the surgical treatment? Well, the laparoscopic fundoplication represents the mainstay in surgical treatment of GERD, because they could potentially correct the esophagogastric junction anatomically. However, there is no effect on the lower esophageal sphincter, and the long-term efficacy is very high, up to 92% of the people. However, this has been related to several adverse events, including gastric or esophageal injury, graft migration, high reparation rates, even dysphagia, abdominal bloating, diarrhea, or even death between 0.1 and 0.2% of the patients. How about the endoscopic option? We have different endoscopic options, including radiofrequency ablation, transoral incision fundoplication, endoscopic full thickness application, and Medigus ultrasonic surgical endostapler. In general, all of these treatments increase the quality of life more than 70% of the cases, and they can decrease the use of PPI in more than 80% of the cases. They have short-term and mid-term good clinical efficacy in more than 75% of cases, and they can decrease objective parameters of GERD evaluation that include the AAT, the Mister score, and esophagitis rate. However, several adverse events have been described, including bleeding, perforation, empyema, or even death. And we have to use very expensive equipment, special equipment, and the availability is compromised. So how about now the endoscopic treatments? We have other endoscopic treatments that include remodelation at the esophagogastric junction. These are the different variants of all of these techniques, including ARMS, ARMA, mucosectomy, peroral endoscopic cardiac constriction, and resection application. All of them has a very good clinical efficacy, more than 75%, low adverse events without mortality described up to now. They can decrease, as well as the other endoscopic treatments, GERD objective parameters of evaluation in up to 80% of the cases, and the quality of life is improved in more than 70% of cases. However, they lack of standardization, and the outcomes are at short or midterm evaluations, and the evaluations are heterogenic. So these have limited use. So this is how anti-reflux ablation therapy is introduced. We look to create an artificial scar at the esophagogastric junction level in order to decrease the reflux of gastric contents into the esophagus. So we started a prospective study since January 2016 up to now. We performed this study in the endoscopy department of the special hospital in Mexico City, Mexico. We included patients with PPI refractory GERD without sliding hiatal hernia and gastroesophageal valve grade 2 or 3 according to Hill's classification. We excluded patients with barred esophagus, pregnant patients, high-grade dysplasia, adenocarcinoma, of course, hiatal hernia, or a primary motility disorder or a major secondary motility disorder. So refractory GERD was defined when after a stable twice daily PPI dosing or single daily in PPI intolerant patients for at least 12 weeks, we presented persistent clinical symptoms, AAT more than 6%, the Mister score more than 14.72, a positive questionnaire more than 12 points, and erosive esophagitis at any grade. So the definitions are as follows. As we can see here, we have 3 different scenarios. The first one is the success, when the AAT is less than 4%. The questionnaire is negative and no erosive esophagitis is found. In the opposite side, we have unresponsive patients when the AAT is more than 6, the GERD questionnaire more than 12 points, and erosive esophagitis more than 3. And partial response that is between these two scenarios. If a patient is on success, they were followed up now up to 6 years now. And after that, during follow-up, we could have continuous success, but we could have definition of partial response or unresponsive. If this happened, we could offer a second ARAT. And in this case, we have the same, a patient with a definition of success and patients who could have a definition of partial response or unresponsive. In these cases, these were considered as failures. So this is the ARAT technique. As you can see here, this is I think a simple technique that could be performed in most of the endoscopic units. And the first thing that we must do is to make an evaluation of the esophagogastric junction. As we can see here, we have to classify according to the Hill's classifications. And we then perform 2 vertical lines with 5 to 6 dots between 1 and 1.5 centimeters of separation with APC forced coagulation. And after that, we perform an elevation with the mucosal injection of saline solution with methylene blue at 0.5%, as we can see here in the picture. And after that, we start with the ablation. We perform a high power ablation with forced coagulation, effect 3 or 2 and 100 watts of power. Well, now we have changed this to 50 watt power. And then we perform an ablation of 270 up to 320 degrees around the esophagogastric junction. And after that, we start with the cleaning of the mucosal debris. We could use a cap to perform this step. And finally, we can see here the ablation is completed. And after 3 months, the esophagogastric junction is remodelated, as we can see here in here grade type 1. So about our results, in general, more of population is at middle age, 38 years old. The questionnaire is more than 12 points, of course. In this case, a median of 41 points. Most of the patients were on double daily dose, type 3 HIL type, and esophagitis grade B. And the AET had a median of 19.4, and most of our patients had a normal high resolution manometry before the procedure. And about procedure, it was very fast, 33.2 minutes. The ablation circumference of 300 degrees, and almost 80% of patients didn't present any adverse event, as we can see here. And during the evaluation, we can see that up to 6 years after procedure, all of the parameters improved. As you can see here, the AT, the Demister score changes, and the questionnaire about the quality of life was improved. More than 80% of the cases, the HIL type 2 and 3 were improved to type 1 in most of the cases, 85% of the patients, and esophagitis grade B or C improved to no esophagitis or even only grade A. And the PPIUs was withdrawn in almost 80% of all the cases that we can see here. And how about the stenosis? Clinically, 24.5% of patients presented soft clinical dysphagia. Endoscopically, 12%, but all of the cases responded to endoscopic dilatations. One session, 50%, 2 sessions, 42.8%, and up to 5 sessions, 7.2% of the cases. And during follow-up, as we can see here, after ARAT, 89% of the cases had a short-term success, and long-term, 70% of the cases, as we can see here. If we add a second ARAT, only 4% is increased, and in the intention to treat analysis, 4% more, as we can see, 2% of failures. The recurrence was very low of 4%, and 21% of patients were lost during follow-up. And as I said you before, almost 80% of patients were PPI off after procedure. So what were the factors associated with the long-term success? We performed this multi-logistic regression analysis, and we saw that 3 factors were related. First, before procedure, HIL type 2, and after procedure at 3 months, when the patient has HIL type 1 or AAT less than 4%. And finally, well, we can conclude that the Argon Plasma technology is an excellent alternative of treatment in today's gastrointestinal procedures. Hybrid Argon Plasma is increasing the safety and efficacy of all of procedures, specifically in high-risk areas such as duodenum or colon. In GERD treatment, ARAT represents a new safe and effective short, medium, and now long-term evaluation therapy for patients with refractory GERD to PPI treatment without hiatal hernia, and with the following results, as we saw during the lecture. The short-term efficacy is very high, up to 89% of the cases, medium-term 78% of the cases, and long-term 70% of the cases up to 6 years after the ARAT. the PPI withdrawal up to 78% of the patients, and the remodeling of the esophagogastric junction up to heal 1 in up to 85% of patients, and healing of erosive esophagitis in 94% of cases, improvement in quality of life in more than 85%, and only 12% of rate of stenosis, but all of them were responded endoscopically with dilatation, and no mortality or other severe adverse events such as bleeding or perforations, and the associated factors with success at long term were before ARAT, HEAL type 2, and after ARAT, at 3 months evaluation, HEAL type 1 and AAT less than 4%. Thank you very much.
Well, thank you, Oscar. That was really impressive and very interesting lecture. I see we have already some questions. So I suggest to move forward to the next lecture. Yes, so I present you Professor Galvão Neto that will talk about treatment for weight regain following Roux-en-Y Gastric Bypass. So Manoel, please, the podium is yours.
Thank you very much, Ivo. So our task now is to talk about the use of APC of weight regain after gastric bypass. So in your screen now you have a drawing of gastric bypass. We have the pouch, the anastomosis, the alimentary limb in blue, the biliopancreatic limb that with the ball in yellow. So what we reach by endoscopy is the first part, the pouch, and the anastomosis on the upper part. And we can see here what is the size of the problem. This is a very good article telling us that obesity is a chronic progressive disease. So you can see here, even on bypass, such a nice operation used to be the golden standard. You can see here that up to 40% of the patient will significantly regain weight after some years of the procedure, and some of them will need an intervention. And how it impacts, how it impacts in the quality of life. So you can see here that depending on years of bypass, more and more patients regain significantly weight, and that as they regain weight, the comorbidities come back. And our theory on how it happens is not only the pouch will dilate over time and the anastomosis will dilate over time, getting away of the initial anatomy. More than that, you're going to have more compliance, so more food will fit on that, and food will pass rapidly to that. So with that in mind, we have those kind of papers showing us that is the larger the anastomosis, more weight regain, and also this one from Abraham Abudai at the time he was in Harvard. You can see here, as the anastomosis goes up and in diameter, you have more percentage of weight regain. With that in mind, we developed ways to measure the anastomosis accurately, and we could replicate the measuring of the previous article. And this whole idea come by chance with Dr. Ahmad Ali. He had 2 patients with post-Roux-en-Y gastric bypass that bleeds, and he applied APC to treat the bleeding, and those patients, they lose weight. So the observation starts, then this whole concept come to Brazil, become popular. You can see here, in this publication, the index publication of Giorgio Barretta was his PhD thesis from Brazil, that he can demonstrate in the figures left, before, and right after. You see first application, second application, third application, how effective it is on narrowing the anastomosis that once was dilated. And you can see here the weight loss that he achieved after the index, and also the percent of reduction of the anastomosis with the sessions up to 3 to 4 weeks each session. And you can see that the anastomosis become narrow. And we could, our group with Sergio Barrichello leading that, could prove that the weight loss comes after the inception of the APC. And you can see here that we measured that gastric emptying of the pouch. It was really altered. We induced the delayed gastric emptying. Some authors even use that to treat like dumping syndrome. And it began very popular in Brazil, and quite some papers done. This is the largest one series with 558 patients that we could have patients 8 years out of the surgery with 2 in the mean intervention with APC, and the initial size of the anastomosis measured by the rules come from 24.4 to 14%. Real statistical reduction on the size of that impacts in weight loss. So look at this graph, just pay attention to the red line, that we could really improve in weight loss and keep it up to 24 months, and then it drops, but mostly because of the loss to follow-up. And also we have very hard evidence, very good evidence, like this beautiful RCT trial of Gustavo Quadros from Brazil, published that. You can see here the effects of APC on the anastomosis size that you can measure. And the ways we do that is the 2 ways to do that. If you have a low power unity like this one, you have to do a contact method. So the damage is much more and much less controllable. And if you use a more precise, a more powerful, a more sophisticated unit like this one, that you can see here, the pulsated APC and the effect too, and you can see using the 360 ball tip catheter, you can really don't need to touch it, and you're gonna have a very good ablation of the tissue. And a little bit different, we intended to cause damage of the muscular layer. So just take a look of this real-time application. It's 5 minutes. If you're well trained and you use a good unity, power unity, you can see here that pretty much it's 2 to 5 minutes and it's done. Patient go home same day. You keep them on PPI, some sucralfate at night, and that's it. And in 3 to 4 weeks, you do inspect another session. So in that paper, there was 22 for the APC and 20 for the diet and clinical follow-up. And you can see here that the safety score after meal, satiety score after meal was really improved on the patients treated. So they have satiety and it translates on weight loss. Let me explain that graph. So see here, both lines, red and black, is that they become of the initial weight pre-Roux-en-Y, then they go to the ESGE, the minimum weight loss, then they progress on weight regain, and in the dotted line are the projected weight regain if you don't intervene. So take a look on the black, that we intervene and they lose weight and they keep it, and also the ones that we follow clinically, we cross it, and you can see a similar curve that, and you can see that those patients that have more than 7 years of follow-up after the bypass to the intervention, and then 14 months of follow-up after the APC. So here is a very interesting graph that you take out most of the possibility of having a sham or like a placebo effect. So you see here, the patients on blue or light green initially intervene with APC, then the follow-up comes like this. And the other ones, in blue is the diet group. Nothing happened. You intervene with APC, they lose weight. And in red, you see the initial intervention and keeping the follow-up. They are almost the same. So it really, really demonstrates the efficacy of this. And the evolution comes to our publication of using Delphi consensus of the Brazilian consensus for APC, and you can see here that those are the doctors that participate. They're very experienced doctors on the method, and look at the numbers: 12,349 patients, and we achieved in 1 year 11.84% of total weight loss in a mean of 2.25 sessions per patient. Complications mostly are stenosis, less than 1%. And you can see here, they can be severe, especially if you go from the second to the third session, you have to clinically observe if you really need that. If it's less than 8 millimeters, it's better to stop, but it can be dilated. And also bleeding, 0.3%. And when it bleeds, you see the treatment, the conservative, fewer injection plus keep, and not just the clips. And one just straight with APC, one hemospray, and one we don't have how they treat it. And perforation, it can happen, is 0.08%. So 8 patients post APC and 3 post dilation. So we can take that apart. Like this case is mine, and it was doing a procedure patient was okay, and 31 minutes after the procedure, when we got to discharge, the patient had this huge pneumoperitoneum that we decompress with a needle, and the patient gets okay. But the next day, we asked the surgeons to intervene. You can see here a perforation, like interesting, not in anastomosis, but on the pouch itself, or possibly by submucosal dissection. We are using not that safe unity, but you can see it was solved by laparoscopy. The patient discharged 2 days after. So that's the perforation post APC. 3 conservative, 3 surgeries, 1 stent, 1 clip. And post-stenosis, we have 3 patients that 2 perforate with conservative treatment, and 1 that's my patient went to surgery with that. So associated mortality, we have 1 patient associated with this method that is 0.0008%. So it's a very safe method on that. And also on the consensus, we decided and we achieved consensus that there was no minimal age, no maximal age, that the bypass should be done at least 18 months before the procedure, and the weight regain should be more than 20% of the lost weight. The stoma size have to be 15 millimeters or more, and they have to comply with the multidisciplinary team support. And in the multidisciplinary team, you need an endoscopist, a dietitian, and psychologist. The workup is that you need a diagnostic ESGE pre, coagulation profile is highly recommended, and general lab tests. And the equipment and setting, we need a proper place to do that. It can be endoscopic suite, can be hospital, wherever. We do CO2 insufflation, we agree on that. And if you're using a lower power, a lower sophisticated unity, you need much more power, like 70 to 80 watts. And if you use a sophisticated units, like the ones we are talking about, you use half of the power to that. And we will end with this one, that's a prospective randomized control trial comparing APC with APC plus suture for São Paulo University that we have proctored in on the suture. You can see here 20 and 19 cases. And at the end, we have analyzed 17 on interventional group and 20 in the clinical group. So, sorry, on the APC and 720 on the APC plus suture. So suture, that is the setup we use. We use this specific unity, pulsated effect to 1.5 liters, 60 watts, and that's the unity we have used. And on the suturing side is the method that we developed there is a semicircular, not go a lot on that, just to show you how the suture goes. And that's the end results we achieved just after this procedure, APC plus suture, so it really can control the narrowing in just 1 session. So the results are pretty much the same up to 1 year. So you can see here that they cross, initially the APC lost more weight, then the APC with suture matches, and they go in 1 year, they got the same data. And we have this meta-analysis that demonstrate that both work, but APC plus suture have a better effect, but APC costs less and can be used with efficacy and safety. So tens of thousands of cases done in Brazil, they are repeating all over the world, and these are very promising with hard and good data to show to you that it works. So thank you very much.
Thank you, Manoel. That was really impressive and exhaustive presentation. So, and now we have Professor Vivek Kumbhari from Mayo Clinic, Florida, that will talk about advancing the role of gastric mucosal resection ablation as a bariatric approach. So Vivek, the podium is yours.
Thanks so much, Ivo. Good evening, everyone. Appreciate the opportunity to speak about a topic that I'm very passionate about, and I suspect it may play a role in how we treat our patients in the future. In terms of disclosures, I am a consultant for ERBE and have received some research support from ERBE as well. So as we think about primary weight loss therapies, and I really enjoyed the previous 2 talks, particularly the last one on managing weight regain after bariatric surgery, let's think about the patient who hasn't had surgery. What do we want to achieve? I think it's important that we have a procedure that is not only appealing to patients as well as referring doctors. So it needs to be safe and it needs to be well tolerated. So it can't be something that causes the patient to feel have a lot of pain, to have vomiting for days on end, or requires an admission and so on. I think we need to get in there early. So BMIs of 27 or above, I think, are suitable for a procedural weight loss approach. It needs to be effective. And what do I feel efficacy means? I think greater than at least 10% total body weight loss at 12 months. That's the minimum. Not only do we need to lose weight, I mean, what people ultimately care about is improvement in the metabolic profile. You know, how is our glucose and lipid metabolism change as a result of a procedure? That really determines the most sinister comorbidities. Obesity is a chronic recalcitrant disease, and so maybe a repeatable procedure would add value. And last and importantly, you know, bariatric surgery is the most effective procedural weight loss strategy. And we don't want to be doing things that compromise a future bariatric surgery if the patient does choose to go down that path. The space is becoming more competitive. You know, we used to think that endoscopic bariatric therapies would be positioned in between pharmacotherapies and surgery. Now we're seeing that with new pharmacotherapies, 20% total body weight losses. This is data from Eli Lilly's new drug, which is a dual GIP and GLP-1 receptor agonist. You know, they saw a 24-kilo weight loss at 72 weeks, and 63% of patients taking their maximum dose of medication achieved greater than 20% total body weight loss. So, you know, as we move forward and innovate in the endoscopic arena, we need to start benchmarking ourselves on surgical outcomes, I believe, as opposed to these sort of 10% total body weight loss where we are. So as we move on to talking about sort of gastric ablation or resection strategies, a quick pivot to the duodenum and why people have looked at the duodenum as a sort of metabolic target. There is some data based on the duodenojejunal bypass liner, which was available for many years in Europe, to show that it did confer weight loss, and it did reduce the HbA1c while it was in situ by around 1%. And so I think it does show that the duodenum, it appears to be a worthy target. However, that particular device, the endobarrier, did have some limitations with respect to tolerability and safety, and so maybe a strategy by Metamodics whereby you drop an anchor at the level of the pylorus rather than the duodenal bulb may be better. It may be safer, better tolerated. However, there is some migration that may be noted with this. So why don't we get rid of all implants? I think we know that the digestive tract is a relatively hostile environment, and implants tend to do poorly. Your gastric balloons can only be there temporarily. We just spoke about the endobarrier and others. Stents that we use in the GI tract frequently, also poorly tolerated. So maybe we should shift gears away from something that's implantable. And so this, I think, is a very clever approach. The fractal procedure, duodenal mucosal resurfacing, involves a submucosal injection and effectively thermal ablation of the proximal duodenum. And what you see in these images here from left to right is sort of the pre-procedure, intra-procedure, immediately at the end of the procedure, and then a 3-month follow-up. And as you might expect, the gastric and duodenal mucosal is rapidly generating, and so you would expect some endoscopic normalization over time. Now, whether the hormonally acting cells are also normal, remains to be seen. And so this is a randomized controlled, double-blind, very nicely done study looking at duodenal mucosal resurfacing for the purposes of treating patients with diabetes. There was very marginal weight loss. We're talking about 3 kilos over 6 months. And as we look at HbA1c, also a very marginal reduction in HbA1c over time. However, it does seem that a single procedure can have, some enduring benefits. And most of you probably heard about the endoscopic sleeve gastroplasty. Dr. Galvão has played a pivotal role in disseminating it globally. This is a procedure whereby we emulate the appearances of the stomach that are seen endoscopically at the time of laparoscopic sleeve gastrectomy. So we take an endoscopic suturing system and run sutures along the greater curvature of the stomach from 3 to 6 centimeters from the pylorus all the way up to the GE junction, and you end up with a small, stiff tube. So that one could argue looks like a surgical sleeve. However, it's a single procedure, no need for any incision. So from a patient perspective, this is very attractive. And so does it work? Yeah, it works. You know, we don't see outcomes that are the same as laparoscopic sleeve gastrectomy, which has, you know, around 25 to 30% total body weight loss at 1 year. Here we're seeing around a 16 to 17% total body weight loss at 12 months. So effective, although not as effective as bariatric surgery, and we'll get to why later on. Here's one of the reasons why it's not as effective, because the stomach doesn't remain tubular. This is a nice study that Dr. Galvão was part of, where we looked at the persistence of the sutures over time. And at 1 year, they found that about 50% of the sutures remained in situ. And this is a video from one of my patients, where you can see that over time, 9 months after their procedure, the sutures tend to dehisce. They just cheese wire through tissue over time, and they probably remain in situ for several weeks to a few months. You do see some fibrosis at the greater curvature aspect, and as you come up more proximally here towards the fundus. And so I think we do a good job of suturing a lot of the stomach, and some of it does remain small and non-compliant, but not all of it. So how can we improve on the durability of this sleeve-like conformation when we do an endoscopic sleeve gastroplasty? Well, can we combine it with argon plasma coagulation? And together with Diego de Moura from Brazil and Adrian Satterredo in Australia, you know, we published the first such procedure whereby we actually took a patient and did a combined ESG plus APC ablation of the stomach. So it's a sort of a normal stomach. We do a general ESG procedure, and then after each plication, we would ablate, you know, at 50 watts or so, the gastric mucosa, and then we'd run another set of sutures, and then we'd ablate again, and so on and so forth, until we come a fair way up the stomach. And sort of this is what you see at the end. So this is a combination procedure of ESG plus APC, and I think this is gaining some popularity worldwide. I think it makes sense, and I'll show you why. This is what it looks like at 6 months later. So really, you see a very nice tubular stomach, much better than all these frayed sutures that you saw previously. So I think there's some value here. These are some images from Adrian Satterredo. This is at the end of his procedure, combining ESG with APC. You see here at 3 months, some pretty robust fibrosis. Once again here at, so that was 3 weeks, and once again at 6 weeks here. So really getting some nice conformational change, which may be enduring. Baham Abedaya and the team at Mayo Rochester have combined resection of the gastric mucosa along 6 areas of the greater curvature of the stomach, together with ESG. So basically resect and take bites through that exposed deep submucosa and muscularis propria in an attempt to constitute some fibrosis and scarring. You can see here a year later on the bottom right that there does seem to be a more sort of scarred down ESG. So I think this is part of the future of the technique. Let's take a step away a bit here and think about why laparoscopic sleeve gastrectomy and another surgical procedure, the laparoscopic greater curvature plication, does seem to have improved outcomes over ESG, despite the anatomical appearances of a stomach and the gastric luminal caliber, the volume being similar. And you can see here in this graph, at 2 years follow-up, the ESGs in the blue had the least total body weight loss over time, compared to the laparoscopic sleeve gastrectomy, which had the most, and the greater curvature plication, which was a close second. From the get-go, they had superior weight loss. So I don't think this is a function. The difference is not, it doesn't seem to be a function of sort of the sutures fraying, because if that were the case, then you'd expect to see weight losses being very similar early on with a separation over time. And we're not seeing that. It seems to be from the get-go and enduring that the total body weight loss is inferior with ESG in its current form. So why is that? Is it because at surgery you get accelerated nutrient flow, increased gastric emptying? Is it because in the surgical procedures, particularly sleeve gastrectomy, there's loss of nutrient exposure to the gastric mucosa? Are there alterations in microbiome that occur at surgery that don't occur endoscopically? What about bile acid metabolism? I think another one is that even with the greater curvature plication, even though you haven't resected the gastric mucosa, you've taken down the neurovascular supply to the greater curvature to free up the stomach to allow the plication. And that may be a reason why its efficacy is superior to ESG. So as we move forward, what are the ultimate goals of an endobariatric therapy? I think as we look to the future, we need to develop an approach that has similar efficacy to bariatric surgery. It needs to be safer than surgery and ultimately more cost effective. And that's what will allow the insurance companies to reimburse it. Now, from a patient perspective, they want an outpatient procedure that's incisionless, well tolerated, and a single intervention. Providers, as endoscopists, want something that's technically simple, ideally performed under conscious sedation, so no intubation. It needs to be safe and effective. And our insurance companies, the payers, or the governments, want something that's cost effective and that has long-term improvement in metabolic outcomes, not just weight loss. And so here's an interesting strategy from China, where they went ahead and actually just did a endoscopic mucosal resection of the entire greater curvature of the stomach, left some islands of normal mucosa. You can see the top right, basically exposed submucosa with some small islands of mucosa to cause the stomach to remodel into this scarred sort of sleeve-like conformation. You may be able to appreciate that endoscopically above and on the CTs below. So you get a small stomach that's non-compliant, that has less hormonally active gastric mucosa. I think that's one of the critical elements here. The gastric mucosa is a hormonally active organ, often underappreciated. So, some years ago, in collaboration with a group in the University of Leipzig and Andy Oberbach's group, as well as Urbe, we did some work using gastric mucosal devitalization or ablation in animal models to see if maybe we can ablate the mucosa to see if we can get some similar outcomes as that seen with surgery. And so not only are we interested in weight loss here, we're interested in improving lipid and glucose metabolism. And so this is an obese rat model where we took rats, made them fat, sort of gave them a high-fat diet, 100 rats, and then fed them, and then separated them into 3 groups: a gastric mucosal devitalization group, the ablation group, a sham surgical group, and a VSG, vertical sleeve gastrectomy group. And we followed them out for up to 8 weeks. And so you can imagine doing an APC in a rat is hard. You still have to do a surgical procedure to ablate the mucosa. You don't really do submucosal injection and so on here. But you can see you can actually successfully ablate the mucosa with APC to model this. And what was found over time, if you look at the data in rats, at the end of the procedure, yes, we were able to successfully eradicate the mucosa. And then at 2 weeks, 4 weeks, and 8 weeks, you see some regeneration in the mucosal layer over time. And when you do immunohistochemical staining for ghrelin, does the abundance of ghrelin seem to come back as much as the histological normalization? And it doesn't. You can still see on the image on the right, there seems to be a paucity of ghrelin cells as compared to the untreated image on the far left. So although there seems to be some regeneration of the mucosa, maybe there's some lag effect in the hormonal secreting cells. And we may see that in inflammatory bowel disease and ileitis. And so looking at the GMD group in the middle here, you can see sort of less abdominoperineal and retroperitoneal fibrosis compared to the sham group, and it looks very similar to the surgical group, which was very exciting. And we looked at some harder endpoints, such as liver lipid content. We actually saw in sort of Nile red staining for fat droplets, lipid droplets. We actually found that there was really no difference between the GMD group, the ablation group, and the surgical group in these obese rat models. And we looked at body weight, visceral adiposity, and subcutaneous adiposity. We saw similar findings. And so let's translate this to the human. So we took a pig model, which uses the same endoscopic equipment as that of human patients. These are human-sized pig models. And we again did a randomized control study comparing the ablation, GMD, to sleeve gastrectomy to a sham group, and of some very robust histological and even sort of MRI evaluation together with organ lipid content and some hormonal staining. And followed these pigs out for 8 weeks. And so we use a sort of modified system, the hybrid APC system, but we had a special catheter that allowed for higher energy settings, which you need in sort of a thicker pig mucosa. And you can see here, we sort of went to town. We ablated a large surface area of the stomach to be sort of brown or golden, honey golden brown color throughout the fundus and body. And when you look at these pigs, you know, very interesting what we found when we focused on weight. We actually found that body weight at 4 weeks was the same in both the surgical and ablation group. However, after 4 weeks, there did seem to be some differentiation, with the surgical group being superior. But certainly the ablation group was far better than the sham group. When we looked at visceral adiposity, there was no difference between the surgical group and the ablation group. So it seems that sort of from that metabolic endpoint, there was no real difference. And again, lipid content was significantly better in the ablation group compared to sham in a skeletal and heart cardiac muscle too. So in closing, as we move to the clinic, the FDA has given us the green light. So ERBE have done a great job in supporting this work, where we're going to do a first-in-human study across the 3 Mayo sites of gastric mucosal ablation of the stomach. So we're going to take the graded curvature of the stomach, ablate the entire graded curvature of the body and fundus, and see if we can remodel the stomach to that of a similar appearance to that of a surgical sleeve gastrectomy. And we're also in tandem also doing some similar clinical work using almost identical protocols in Brazil with Dr. Demora, both Eduardo and Diego, and Adrian Sadareto in Australia. So in summary, you know, the benefits of bariatric surgery go beyond that induced by volume restriction alone. I think as we move forward in the space, we need to consider developing approaches that are free of a device to improve tolerability as well as durability. We also want to develop a method that tends to not fight against hormones. We know that when patients lose even 20, 30% of their total body weight loss within 6 to 12 months of bariatric surgery, they're not ravishing. There's something that allows them to lose weight with relative ease compared to a patient who's having sort of diet-induced weight loss of 20%, where they're constantly hungry. So what is that critical element? We need to find it, and then we need to leverage that to create a viable endoscopic approach. So I'll stop there. Thank you.
Thank you, Vivek. Really, this is really amazing lecture, and only comprehensive with animal studies and translational. And I hope really that this will become future treatment. Let's see what will happen in your human studies, and I hope you can really make this translation so everybody can do it. So I have a question for Oscar. Oscar, I didn't, so you didn't mention pH, impedanceometry, and manometry in your patients for the selection of your procedure.
Yes, Ivo, all of the patients underwent to both procedures, to the pH, endoscope during follow-up, and before the high-resolution manometry in all patients.
And pH impedanceometry?
Yes, we did it in all patients during the follow-up and before procedure.
Oh, that is impressive. Well, this is very cost effective then. Treatment for GERD and for these patients that usually it's difficult to give them a medical solution, and sometimes also with medications it is difficult to control the treatment. Yes. Manoel and Vivek, do you have questions for Oscar for his presentation?
Yeah, Oscar, it doesn't was very clear to me. What was the setup you had used?
Yes, we used APC Forte Quad, Defect 2, 100 watts. But now we are performing this with 500 because we are not compromising the therapeutic effect. But at the beginning of our study, we were complaining about, because of the cushion that was very big, wanted to make a more deep ablation. So 100 was how we think that was the best in that time. Now 50 watts is enough, I think.
50 watts with cushion.
50 watts of ablation. The APC.
But with the cushion or without the cushion?
With injection or without injection?
With injection, yes, of course, with injection.
Maybe Oscar, a great presentation, fascinating work when it came out, got a lot of excitement. I had two questions. First, I was very fascinated by the Hill 3 patients that you're doing this on. I would presume Hill 3 means a small hernia. Do you sometimes ablate in the hernial sac, effectively, maybe in the chest? And do you alter settings there, or are you more cautious? And secondly, any experience in the post-bariatric surgical patient, particularly the sleeve gastrectomy, where there seems to be a high predominance of reflux there?
Well, we haven't performed this in bariatric patients because in our hospital we don't used to see a lot of this kind of patients. However, about the first question, we only make the ablation at the esophageal junction at the gastric side, only 1 centimeter before the C line, so in the esophagus, and we didn't find stenosis, no more than 12% of patients. We think that this is because of the big caution that we perform with the hybrid APC.
Great. I see there is a question for Vivek. Ahmad Roste asks, can we use APC ablation to reduce ghrelin and to reduce appetite?
Yes, so I think ghrelin is a very interesting hormone. I've thought a lot about it. Many of us have in the space. For those who may not be aware, it's sort of the only known hunger hormone, sort of pro-hunger hormone, but it has other influences in terms of reducing blood pressure and motility as well. There have been pharma studies that have leveraged sort of ghrelin as a target, and they haven't been borne out to be particularly successful. And so I think that the challenge with thinking about these individual hormones is that the body has so much redundancy. You hit one hormone here and 20 other hormones will rebound elsewhere. We're just too complex, and we intentionally built with this redundancy to survive. However, could doing APC to ablate the gastric mucosa, which may have other hormonally active sort of molecules, some that we may not have even discovered yet, could that be potentially helpful? I think so. I think the APC strategy may have a dual benefit: one, addressing some of these hormones, and two, scarring and reducing volume. We don't know which is the most profound, but in some of that early animal work, we're actually able to have significant metabolic improvement by just doing superficial ablation, whereby we thought we just sort of get rapid regeneration without sort of altering the shape of the stomach. So it's fascinating, and people have looked at left gastric artery embolization. You probably heard the radiologists that they actually send these little microbeads through the left gastric artery to ablate the fundus. As you know, it's almost impossible to ablate the stomach. There's again too much redundancy there. So effectively, you get maybe some transient ischemia. And they actually showed that they were able to reduce ghrelin even with that process. So, I think it's part and parcel of all that's going on, but probably not worthy to focus purely on ghrelin alone.
Thank you. There is another question for you. Does the APC have any effect of the ESGE sutures? I think probably Abdul Mavas thought that you could cut the sutures with the APC.
Yeah, so it's an excellent question. As we all know, the argon tends to arc to the tissue, not so much to the suture. So I think as long as you're not too aggressive, such that you basically sort of remove the sort of tissue where the suture is going through, you'll be okay. Now, the idea with ESG, as sort of Manoel has all taught us, is to really go full thickness, grab that wall. And so I don't think, we don't get sort of full transmural thermal effect when we do APC. It's sort of relatively superficial. And so I don't think that's too much of a case. We haven't observed it so far.
What is the amount of watts you use for that?
Yeah, so we use the ERBI system. If you use the VIA 300D, it's sort of effect 250 watts. And you're right, 50. No submucosal cushion, and you sort of
why you do not do it before suturing?
So you can. It sort of tends to mean that you'll ablate a greater surface area this is sort of cheating a bit here. You bring tissue together, a small target, bring tissue together, a small target. So it's sort of a more efficient process, we believe. And it can be a little yucky to sort of take these bites through tissue that's been ablated. And we sometimes see this, you know, with the gastric outlet reduction procedure that Manoel talked about. Whenever you take these bites, you get this sloughing off of tissue that tends to cake the lens, and it just becomes more arduous. So sort of more sort of endoscopist focused reasons rather than sort of true pathomechanistic.
So I'm just curious, just in 1.5 minutes, Manoel, what do you think about this?
Well, I think if you see the big picture, my friend Vivek, what you're gonna do if you need to do anything with the stomach later. Obesity is a chronic progressive disease. My side, I prefer to have a stomach that I can re-intervene. I prefer to have a stomach if the patient is not as successful as we wanted to, that the surgeon can do wherever he wants. And one of the beauties of the ESG is versatile. So we can do that. So as much as you target efficacy, in terms of durability with those methods like APC plus suture or just APC, or even what the radiologists do with the gastric artery, I see this, it is okay. I think it's very valid. You are about to show us with very hard and very good clinical evidence how it works. But down the road, and it's something that the bariatric surgeons, they're concerned about that, because if you follow a patient for 10 years, they will have at least 2 procedures for weight regain. And what we are doing, we just saw that with APC. So why not get something more versatile? But you know what? There's no answer. You will provide us the answer. So I was focused on providing answers on APC for these 10 years. And we got through all these RCT trials. So now you see here that on Roux-en-Y Gastric Bypass weight regain, we have evidence that nobody can deny. So we cannot even ask for more evidence. So, and I think that the way you're doing is the right way to do it. So you're providing the correct evidence. So I prefer not to think about it, but the way I think right now is that I would like to have this stomach in a way that I can do wherever I want. And thinking about, I'm a surgeon as well, so looking for the next guy who's going to treat this patient down the road. But again, it's just an observation, Ivo, and I think Vivek work the way he's doing with FDA support and approval, the herb support. You're going to have the answers to us in a few years, Vivek.
Thank you, Manoel. So we are just right in time. It's 6:00 p.m. Thank you, everybody. Thanks to the attendants that were so patient, and a lot of people were here with us. Thanks to you with your high quality, high profile lectures. So hope to see you in the next ESGE webinars. Thank you so much, and bye-bye.
Thank you very much.
Thank you.
Bye.
Bye.